Good afternoon. As we have seen, diabetic medications are standing between your patient and uncontrolled diabetes. Inclisiran is standing between dyslipidemia and your patient. I am standing between you and your lunch. So bear with me for the next 10-15 minutes. We'll try to cut short as fast as we can. So today's topic allotted to me is what are the changes we are observing in terms of guideline-directed medical therapy while we are managing patients with HFrEF. We all know that mortality with HFrEF patient, heart failure with reduced ejection fraction, the mortality is significantly high. And we all have seen in our practice, like when we were managing those patients, we didn't have a track. But once we start following up these patients, you find the mortality is significantly high. In hospital, mortality is around 10%. 1 month mortality is around 14%. 1 year mortality is 33, almost 1/3 of a patient you lose by the end of 1 year, and almost 50% patients you lose by the end of 3 years. So if you see, because of HFrEF, the mortality is so significant and so high. Why HFrEF has gained more importance? Because the prognosis, survival, and treatment of all other cardiac morbidities, they have improved. And all cardiac morbidities, longer the patients live, ultimately they all culminate, either hypertension, HOCM, ischemic heart disease, valvular heart disease, everything ultimately culminates into heart failure with reduced ejection fraction. This is why now we are getting more and more patients with HFrEF because of increased survival because of other disease, as well as because of increased diagnosis of this disease. Lack of GDMT, as we all know, it has very high risk of mortality if the patients are not on GDMT. This problem is more so in Indian patients, because in Indian patients, the GDMT still penetration is significantly low. You see in this data that this is a Trivandrum heart failure registry from Kerala, and this shows that less number of patients, they received guideline directed medical therapy, and if they receive less or suboptimal therapy, the mortality is significantly high. And GDMT definitely, this remains an essential way to combat heart failure. Now, we all know heart failure has significant mortality, but in last 5-7 years, if you see, there is significant improvement in the medical management of heart failure patients, particularly after the appearance of ARNI on the dais, as well as after appearance of SGLT2 inhibitor. Beta blockers and MRA were there, but their role also has been increasingly recognized. American guidelines, European guidelines, ACC, AHA, Heart Failure Society of America, everybody jointly recommends that all the patients with HFrEF, they should be on guideline-directed medical therapy to improve their survival, to improve quality of life, and to decrease their heart failure hospitalization. We are taking this hypothetical case, which is a real-world scenario, which we see, and this is just for mind churning. She is Radhika, 58-year-old female. We see in our clinical practice daily. She was diagnosed with HFrEF 4 years back. Now she is in NHA class 2. She can do her routine activities. With sometimes she has to pause for some breath. Otherwise, she can perform all her routine activities normally. She is on beta blocker, she is on MRA, and she is on ACE inhibitor, which was the standard therapy 4-5 years back. For routine in evaluation, her echocardiography revealed her ejection fraction is 35%, falling in HFrEF category. Anti-proBNP absolutely normal. Kidney, blood pressure, BMI is slightly on the higher side, or the biochemistry is normal. So your patient has normal biochemistry, ejection fraction 35%, is all standard therapy of ACE inhibitor, beta blocker, MRA, and having NHA class 2 symptoms. So what would you do next in this patient? Would we do anything, or would we just continue to follow? Just 10-second pause for answer. Anybody would like to volunteer? So if I go back in the previous slide, patient is already receiving beta blocker and diuretic, MRA, and ACE inhibitor. If my patient's anti-proBNP is 125, I would reduce the dose of diuretic. Probably I can remove the diuretic, number one. Number two, my patient is still NHA class 2 without in a phase of volume overload. It means she further needs a drug modifying therapy. I would switch from ACE inhibitor to ARNI, which is the class 1 recommendation. And third change, but still patient is not there on SGLT2 inhibitor, I will add SGLT2 inhibitor. So you see, the patient who has 35% EF, largely asymptomatic, good biochemistry profile, is still in that patient also, if the patient comes in follow-up, these are the changes one should be considering and one should be making. So this was regarding initiating and continuing GDMT keeps real-world HFrEF patient live longer and out of hospital. And patients who are not on GDMT cohort, they have almost 29% increased risk of mortality compared to GDMT. So if your patient, because of no reason, if your patient is not on any of the 4 pillars of GDMT, you are not doing justice with your patient. So every time you have an interaction to have a HFrEF patient, please remind yourself whether my patient is receiving guideline-directed medical therapy or not. If not, then why not? If receiving, why this dose? Can I escalate the dose? Does the patient need some modification or not? Do not settle down with some mild symptoms or just because LV is okay, my patient is doing okay, still they need some optimization of therapy. So guideline-directed medical therapy in HFrEF, American guidelines, they recommend that hospitalization is the best opportunity. And we all have seen hospitalization when the patient is hospitalized with acute heart failure or acute decompensated heart failure. That is the best time when patient is most receptive. You have maximum time to initiate and up-titrate the RNA or heart failure GDMT guideline-directed medical therapy. That is the best time patient will receive more information, patient is willing to take, family is willing to take, and they are willing to understand the disease, which will help you managing these patients for longer. So hospitalization is a critical opportunity. Never miss that opportunity while starting and optimizing the dose of GDMT. And if your patient was already on GDMT and patient has been hospitalized, do not just discontinue. You might need to discontinue certain therapy if the patient has volume overloaded state, you are diuresing the patient aggressively. You might need cut down on RNA. You might need to cut down on potassium depending on his potassium profile and all these things. But do not unnecessarily discontinue GDMT. Continuation of GDMT also improves patients' chances of rehospitalization and improves survival. So the American guideline recommends the RNA circulating valsartan as the first line therapy for all HFrEF patients. If your patient is on ACE inhibitor or ARB, patient is LMHA class 2 and above, they should be switched from ACE inhibitor ARB to RNA. Even if the patient is ACE inhibitor ARB naive, patient has not received, first time diagnosed, first time came to OPD or ER, still these patients also can be directly started on RNA. But mind it, when the patient has come in ER or in ICU, when the patient is in volume overloaded state, you are aggressively diuresing this patient. Patient is not euvolemic. That is not the best time to start RNA. Make a patient euvolemic, remove the IV diuretic, have a stable dose of diuretic and then start. But do not wait that my patient will be discharged, will come in OPD, more stable condition, then I will start. You are going to start before discharge in the hospital setting itself. European guidelines, they also mention same thing regarding RNA. There is a first-line cornerstone therapy for all HFrEF patients, and initiation of RNA is recently hospitalized patient, stable patient with HFrEF, including those who are ACE inhibitor and ARB naive, is safe and should be considered. Same thing, American, European, all guidelines say. And this evidence backing the use of RNA, we know, paradigm heart failure, paradigm HF trial, large trial, almost 13,000 patients, and this established the role of RNA in decreasing. And you know, this paradigm, the beauty of this trial, this was not against a placebo. This RNA was studied against already established molecule enalapril. So enalapril had already established role in heart failure. It was studied against RNA and enalapril, and here RNA has showed over and above advantage in terms of CV modality, in terms of heart failure hospitalization and composite effect. So this advantage of decreasing 20% CV death and decreasing 21% heart failure hospitalization is not against placebo. This is against a molecule. So this shows the robustness of this molecule and the effect. After titration of sacubitril valsartan in OPD heart failure patient, it has been seen that 61% patients, they reach to the maximum tolerated dose by 26 weeks, which is pretty slow, but there are various reasons. Second thing, if you are up titrating or titrating the dose of RNA, it does not prevent you in any way in majority of other optimization of other GDMT therapies. So if your patient is on beta blocker, if your patient is on MRA, if your patient is on SGLT2, you can start, initiate and titrate the doses of other GDMT therapies irrespective of RNA. So it doesn't compromise your up titration of other molecules, which is important. Now, what is the status of use of RNA in India? You see in this data, which is as recent as 2022, the use of RNA in India was in less than 4% Indian patients. Less than 4% HFrEF patient, they are in RNA. And if you see, when we receive the prescription in our OPD, in a hospital, and we find the patients coming from periphery anywhere, they are barely patients who are the genuine HFrEF patient, they are on RNA. So this is the area which needs a significant improvement. Second thing, still there is a mind block. Like if the patient has HFrEF but doesn't have diabetes, patients were not started on SGLT2 inhibitor. SGLT2 inhibitor has established its role in non-diabetic HFrEF patient. So each and every patient unless contraindicated should be on SGLT2 inhibitor. We don't see patients HbA1c 4.5, 4.3, 4.9. If my patient has HREF and the patient needs medicine, every patient should be on SGLT2 inhibitor. Many times happens that when the patient goes for prescription refill to the pharmacy, the pharmacist asks, are you having diabetes? Why are you on this medication? Then patient comes and asks us. So all these kind of myths should be broken. What is a major barrier to medication titration? So I'll go to the major, if you see, there are many barriers are there in our head regarding these three molecules like ARNI, asymmetric ARB and beta blocker, because most of the time we keep titrating regarding these because in vivo SGLT2 it doesn't need any biochemical or metabolic or hemodynamic profile. If the patient doesn't have any UTI, you can start this patient on SGLT2 inhibitor. It doesn't need any dose titration. For these molecules, we need dose titration. But if you see the data, the patients who were having HFrEF and were not on these molecules like asymmetric ARB, 67% patients who were not on asymmetric ARB, there was no reason why they were not on asymmetric ARB. 22% patients, they had hypotension, some had hypokalemia, some had renal impairment. So those are the genuine indication, hypotension, renal impairment, hypokalemia. But what regarding the 67% patient? And same thing stands for beta blocker and ARNI also. If you see in ARNI, 72% patients without any reason, they were not on ARNI. And 16% patient hypotension, some with hyperkalemia, some with renal impairment. So what about the remaining 28%, 72% patient? 28% patient, they had a reason of not being on ARNI, but 72% patients were devoid of ARNI, not on ARNI, without any reason. And if you again go back and scrutinize your OPD practice, you will find it is so true that many patients, just because we have not started, it is not ever started. And this is where the hospitalization becomes a key point. Like if the patient is hospitalized, revise the therapy, take some time, find out why some molecule is not there. Always have this checklist of these 4 GDMT therapies, if they are there or not. If not, why not? Is this dose sufficient or do I need to increase the dose? Now, the common barrier, which is practical also in our mind also, what are the main barriers in GDMT, particularly in ARNI? Hypertension, we are feared if I start, my patient's blood pressure is already 100, can I start ARNI? Hyperkalemia, potassium is 4.55, it will cause hyperkalemia. Renal impairment, creatine 1.4, cardiac renal syndrome, can I start ARNI or not? So we will break this myth one by one. Hypotension in HFrEF therapy, this is challenge. If your patient is having hypotension with HFrEF, if the patient really is hypotension, it means this will cause further organ hypoperfusion, further worsening, and this will cause further it will set in a cycle where all the organs will keep compromising. Hypoperfusion, AKI, further worsening of the heart failure, more volume retention, more heart failure, further decrease in cardiac output. So in this patient, actually this cycle has to be broken. And how will you break this cycle? Patients with heart failure, they have activated, we all know RAS and sympathetic system is activated, which causes vasoconstriction. We need to break this vasoconstriction. If you are giving RAS inhibitor, beta blocker, MRAs, what they will do, they will break this RAS inhibition and sympathetic overactivation. They are going to cause decrease in heart rate, they are going to cause vasodilatation. This is how they are going to antagonize. And by causing these things, they are going to cause some lower blood pressure also. We are not giving this molecule to decrease the blood pressure, but because of the virtue of effect, they are going to cause this lower blood pressure. But this lower blood pressure is not actually hypotension. We confuse a blood pressure of 96 or 100 as hypotension. This is that patient's blood pressure. And this is a marker that my patient's therapy is effective. And the concept of hypotension in these HFrEF patients, if your ejection fraction is 60%, for you 140 is hypertension. If your ejection fraction is 20%, can still 140 be hypertension? If your heart is normal, more than 140 BP is creating a lot of hemodynamic stress on LV. If your ejection fraction is 15%, what would this 140, 130, 120 BP will do? If you keep the blood pressure lower, the cardiac output will improve, the wall stress will decrease, and only then the cardiac performance will increase, cardiac remodeling will decrease. So this is where in these patients with HFrEF, the ejection fraction is 15%, 20%, 25%, we deliberately keep BP around 100, 110. Because 100, 110 is enough to maintain the organ perfusion. It will not cause any end organ hypoperfusion, but also it will decrease my myocardial wall stress. And by decreasing myocardial wall stress, is going to increase my myocardial performance and will further improve the cardiac remodeling. So diagnosis of hypotension cannot be relied absolutely on the value of blood pressure. If a patient is having 96 blood pressure, but he is having a good urine output, biochemistry is fine, patient is not having any hypotensive symptoms, this patient is absolutely fine. It is not warranting any stoppage or down titration of therapy. If the patient has hypotensive symptoms like postural symptoms, then only it means I need to work on something, I need to look for what needs to be done. Therefore, any change in therapy of symptom of hypertension should be noted. This is not the number. If the patient is having symptomatic symptoms, then only should be noted. Now, if your patient is having postural hypotension, what would you do? What we do is we first go and stop ARNI or ACE inhibitor, because we find that can cause hypotension. But actually, how it should be done? You see the signs of congestion are there or not, like our patient. If the signs of congestion are not there, what diuretic is doing there? Because it has no mortality advantage in a stable and euvolemic patient. You decrease your diuretic, you remove your diuretic, most of the time your hypotension is because of your diuretic. You discontinue diuretic first, decrease the dose, and then you reduce the dose of nitrate, isolazine and all these molecules. At last will come when you will start touching the RAS inhibitor like ARNI. Once you have removed all those molecules, still BP, symptomatic hypotension is there, you will decrease the dose of RAS. Otherwise, majority of times by correcting the dose of diuretic and nitrates, you will be able to achieve the good blood pressure and remove symptoms of this thing. So, impact of secondary valsartan and low blood pressure, it has been seen even in patients with low BP, there is 12% reduction in the risk of CV death or heart failure hospitalization. And those patients who have adverse event of hypotension also, there was significantly lower risk of death with ARNI compared to those who were not on ARNI. So even if your patient had postural hypertension, had giddiness, you documented postural hypertension, still in these patients, the ARNI works and has its benefits. The second problem is hyperkalemia. Like hyperkalemia is also one thing which we don't want in a heart failure patient. The heart is already weak. The profile, these patients are already at the higher risk of arrhythmia. If the potassium is on the haywire side, the risk of arrhythmia further increases. So that is the last thing we want. And in HFrEF patients, there are many reasons, like diuretic can cause, MRA can cause, ARNI can cause, and other molecules also can cause. Sometimes diet also, they are very choosy, and after having some heart event, they are going too much on the coconut water and fruit juices, which also can cause hyperkalemia. So, a growing number of CKD and heart failure patients taking RAS inhibitor and MRAs, hyperkalemia has become more concern. And we have seen, as in the previous talk also, now heart, kidney, diabetes, you can't separate them. Heart, kidney, diabetes, we all need to learn each other's subject. So, hyperkalemia increases with decline in renal function. As you see, if the GFR is good, the incidence of hyperkalemia is less compared to if GFR is less than 60. But with MRA inhibitors, in patients those who have worsening renal failure, if the patient doesn't have worsening renal failure versus a patient has declined worsening renal function, again the chances of hyperkalemia will increase. So same thing, if the kidney function is compromising, we know the chances of hyperkalemia will increase. So if your patient is having renal function, you will titrate the other molecules. And impact of hyperkalemia in ADHF patients, 9% patients admitted with acute heart failure, they have hyperkalemia. 10 to 38% patients hospitalized, patients who have ACE inhibitor, they develop hyperkalemia during hospitalization, and 10% patients prescribed an ACE inhibitor develop hyperkalemia within 1 year. So we know this has its effect, but there are many other factors which are responsible. So what is the impact of ARNI on serum potassium level? If you see, compared to enalapril, the level of serious hyperkalemia was significantly lower compared to ARNI. Enalapril we were using, but we are concerned and afraid regarding ARNI. And the incidence of hyperkalemia is lower with ARNI compared to enalapril. Incidence of severe hyperkalemia is significantly lower, like potassium less than more than 5.5 was almost equal, but potassium more than 6 was significantly lower, like life-threatening hyperkalemia is significantly lower with ARNI compared to enalapril. And renal impairment, I'll touch it short. In all these patients, like in heart failure patient, gradually the renal function compromises because of chronic hypoperfusion and because of the diabetes, heart failure, renal dysfunction. We have seen that this becomes almost intangible. There is lower incidence of elevated serum creatinine in patients with ARNI compared to enalapril. If the patient is on ARNI, the rise in creatinine is lesser with ARNI compared to the patient who are on enalapril. And the discontinuation of treatment because of renal dysfunction is also lower with ARNI compared to enalapril. And these are not against placebo, these are against a standard molecule. So the molecule which we are using compared to that molecule, the discontinuation rate, the worsening of renal function, the rise in creatinine is lesser with ARNI. And if the improvement of eGFR has also been noticed compared to enalapril. And ARNI reduces the risk of worsening renal function compared to enalapril or 11% reduction was seen compared to enalapril. So we'll cut short if there is any important. So, why we have mentioned this thing, because many times it is our mental block which keeps us away from GDMT, particularly regarding the hyperkalemia or hypotension or worsening renal function while using ARNI. We know SGLT2 inhibitor is safe, but it skips our mind. Many times when the prescription comes, more than 80% prescription, it doesn't have SGLT2 inhibitor, which is a simple and safe molecule to be started. ARNI gives so much advantage, but just because of the fear of that 5-2% of disadvantage, we divide the patient of 95% of advantage. So, the lack of GDMT is associated with significantly higher risk of mortality in Indian patients. As you have seen, just 4% patients, they are receiving ARNI. ARNI is recommended in first-line therapy in all HFrEF patients unless contraindicated, and it is a good safety profile, significantly lower risk of death despite hypotensive event, hyperkalemia less common than enalapril, and significantly lower rate of rise of or worsening of renal function compared to enalapril. So the practice should be, if you encounter your patient either in emergency or ICU or ward in OPD, any patient with HFrEF, make a checklist. Try to have all the molecules in your prescription. If not, then ask yourself why this prescription or why this molecule is not there in your prescription. Thank you so much.